Alrighty, well, we'll jump right in. Very warm welcome this afternoon in November, a beautiful afternoon in November. I just wanted to start by giving a notice that this presentation is being recorded in video format by Alberta Health Services, and the recording may be used and disclosed by AHS for educational purposes, may be further broadcast by AHS for other presentations, publications, or promotions. It may include conversion to digital format, storing, and publication on AHS webcasting technology. So I'll just take a moment to introduce ourselves as the co-chairs of the PEAS Roles and Implementation Working Group. I have the privilege of co-chairing this working group with Vanessa Steinke, who's our Senior Project Manager for the PEAS project, and she is a Project Manager Extraordinaire. Tricia Miller is the Manager of SLP, Audiology, and Children's Allied Health in the South Zone. And I am Melanie Matisse-Dewar. I'm a Unit Manager at Alberta Children's Hospital, overseeing allied health, rehab professions, and programs. As far as the objectives for today, the focus today is what tools are available to you, to your teams, and families with respect to roles in pediatric eating, feeding, and swallowing services. Our objectives specifically are to share the collaborative practice toolkit that was created by this working group, to review the information and evidence around role clarity, which guided our development of role resources, including tools to assist teams to work through role clarity discussions, and to give a broad overview of collaborative goal setting and share some resources around this topic. Our working group is driven by the evidence-based fact that interprofessional collaborative teams are key to eating, feeding, swallowing, safety, and success. Just wanted to make a quick mention that we have provided training across the PEAS working groups to introduce new tools, a clinical practice guide, and collaborative practice supports that are all available through the PEAS website. And although most of our training sessions are now wrapping up at this point, we did have some in the summer and just some over the past couple of weeks. If you didn't get a chance, or if your staff didn't get a chance to take part in those live events, all of these sessions are recorded on the PEAS website, and you can find them there. And one more just quick housekeeping item. If you do have comments or questions during the presentation, we welcome them. Please do write them in the chat box, and we will address them at the end of this session during some time for a Q&A session. Thanks. I'll pass it over to Vanessa.
Hi, thanks so much, Melanie. So we know that many of you have already heard about the PEAS project, so I'm just going to give a really quick overview of what it's about for anyone who may be new to it. So the PEAS project is a provincial quality improvement initiative to develop a clinical pathway to standardize and improve care for children with pediatric feeding disorders as defined by Gaudet et al. In the Journal of Pediatric Gastroenterology and Nutrition. For this phase of the project, our target population is children in the ambulatory care setting, and so we've focused a lot of our resources on the outpatient and community care settings, but they can very easily be adapted for other settings such as acute care. So at the outset of this project, we hosted 2 World Cafes in northern and southern Alberta to understand what was working and what wasn't working for the care of children with eating, feeding, and swallowing difficulties. And the results were very homogeneous across the province, regardless of where people lived. Interestingly, the most significant barrier to care, which I think probably isn't a surprise to people, is just simply access to service and access to information. But a very close second was actually role clarity and communication. So these are just some examples from the World Cafe of the issues that were concerning families and healthcare providers on those topics. And you can see some of the topics included service silos, goal setting, lack of multidisciplinary care. And that's why the PEAS project has a multidisciplinary provincial working group involving leaders, healthcare providers, and families to develop tools and support improved role clarity, interprofessional collaboration that is family and child-centered. So we're looking forward to sharing these tools with you today, and they can all be found on our website here at peas.ahs.ca. Today we'll just be navigating you through the collaborative practice role resources for healthcare providers, but we encourage you to watch the other presentations that give you a high-level overview of the rest of the website and the clinical practice guide. One other quick mention is that the website is mobile friendly and it's easy to share with families that way as well. So we are really delighted to have a few special guest speakers joining us today, including Julie Evans and Carmen Lazarick from HPSP, and they'll be introducing themselves shortly. But first, we'd like to introduce you to Mona Dhanda. So Mona couldn't be here today. We're going to play her recording, but if you've had the opportunity to attend the CPG session, Mona shared some of her family's story as it relates to clinical aspects of care, and in this presentation, she shares her journey as it relates to collaborative care, roles, and goal setting. And in addition to being a mom of a child with an eating, feeding, swallowing disorder, Mona is also an IT project manager for AHS, and we've had the privilege of working with her to launch our new PEAS website.
Thanks, Vanessa. So this is a picture of my daughter, Isha. She did and still has challenges with feeding herself and receiving the appropriate nutrition she needs. And so then to give you some background on history on her, she was not premature. She was born, she was in distress, and so we had an emergency C-section. She had congenital heart failure. She had respiratory issues. There was that unknown diagnosis of trisomy 21. And she was taken by stork to the Royal Alexandra NICU, and we spent 4 weeks there where she was on a feeding tube, and she was also diagnosed with permanent hearing loss when we were there. And then next slide, please. So during the first year of Isha's life, we felt very supported. Although we didn't have specific assistance with feeding, we were seeing an SLP at the Edmonton Down Syndrome Society. We saw an SLP at the Connect Society. We received physiotherapy from home care, and then we had, all of our specialists and so on. We also had referrals to the Glen Rose. At the time, I declined that because I thought we were double dipping services. I saw that we already had 2 SLPs, one for hearing loss and one for Down syndrome, but they both focused on her speech. And so we didn't really have any assistance in feeding and swallowing. And I guess that was, I didn't know that that was the role of an SLP or an OT at that time. I also didn't know how complex, the basic skill of feeding yourself would be. And because Isha had a cognitive disability, I didn't realize that that was something that could be taught as well. And so, 8 years ago, I wished PEAS existed because I would look at this circle diagram that you have under the care coordination section in PEAS. And I would have likely understood the type of providers that I might have had involved in our life. I would have definitely sought some intervention at that time. I hope for new families that they can look at PEAS and learn about coordination of care and realize that regardless of where their child is in their journey, they'll have some support and who they can turn to. I eventually did learn all of this, but not until some years later. And I do believe in early intervention, so I regret some of the choices that we made. Now the next slide is her toddler years. Isha progressed. She was able to eat soft foods, and I started getting her to swallow foods. I would dose everything in yogurt and cut it up into small chunks. But that was even, not sustainable. And then also on top of that, you can see that she was really challenged in terms of getting food into her mouth on her own. So we did our best, but if I had PEAS at that time, I think things would have changed for us, not just in terms of teaching her how to feed, but in terms of ensuring I had the right emotional support. I did seek counseling at that time, and there's a self-care section in PEAS that provides a lot of options for families that are experiencing overwhelm. At the time, our SLP was costing us $180 out of pocket, and we're currently paying $135 for 45 minutes. And 60% of that comes out of pocket because of, the type of healthcare I have here at AHS. And so PEAS also explores different funding options that are available to families. And so I actually decided to seek intervention because at this time we completely isolated ourselves. We stopped taking her to birthday parties, and I had a terrible attitude. I didn't want to see other children thriving because I was jealous, and that was actually hurting her. Keeping her from those gatherings was, not beneficial for anyone. And so now when I look back, like, we've experienced collaborative care. There are a lot of things she still can't do in terms of feeding and other functions, but I'm not bothered like I was before. And I think the key difference is that I know that I've experienced collaborative care. I know that with the right assistance from the right type of team, that there are things I can do to help her succeed. And I think it was that feeling of not knowing what to do that really depressed me at that time. And so move forward, 3.5 years later, we received specialized services. And so we had a great team. We had an OT, behavioral consultant, SLP, and SLPA. And we had a communication book that we shared amongst each other with quarterly reviews. It involved everyone on the team. Our clinicians kind of worked together, so they would share their notes with the other disciplines, so we didn't have to communicate our goals over and over again to them. We would do family goal setting, so that would keep us on track and we were all on the same page. And actually, I would say that feeding was the largest group effort because it involved everyone on the team. We had to use the right language, work on her posture, work on jaw alignment, and we had our behavioral consultant that would help her to get excited for food and not frustrated because all she wanted to do was just drink yogurt and ice cream. Previously, we had 2 different SLPs, and that was also stressful from 2 different organizations because they would give us advice that would clash, and it was hard to decide what to do. The other great thing I thought about collaborative care was that they looked at our needs as a family and not just Isha as an individual. So everyone got involved, including my older child and my younger child, and so it was really amazing that we all had a role to play to help Isha, and they taught us how to provide care and give us some tools in our back pocket to give us confidence and help us to assist her. And so now, the next slide, please. We transitioned to school, and so now Isha's in a community school. She's repeating grade 1, and she has to decide whether she goes to recess or she eats food because she just doesn't have time to do both. And so that kind of results in some behavioral concerns, and she's fatigued by the end of the day. And I realized that it's complicated in terms of the school board has their own OT and PT and the teacher, and so we're not sure who's involved in helping her to feed because they all are very busy and you're working on helping an entire class. But we do know that throughout our journey, we've had a constantly evolving care team, and we've experienced different type of care. And I can strongly say that we've been the most successful as a family when we were part of a multidisciplinary team. I am so excited that teams are focusing on collaboration and that PEAS makes all the resources available to families. I'm really hoping that the information on PEAS is going to provide families to be more proactive rather than reactive, as I feel that we were the last 8 years. If I would have known, or families know that and understand right from the beginning that they're not alone on this journey, and they in fact could have an entire team of medical professionals at their side, it will reduce the feelings of overwhelm and ultimately provide better care for their children. Thank you so much.
Good afternoon, everyone. This is Julie Evans, and I'm the Practice Director for Provincial Speech Language Pathology. I'm grateful to have the opportunity to be part of the leadership team for PEAS, and as such, I have the pleasure of just offering thanks to Mona. Really want to thank her for sharing her journey and her learning along the way. It's just a joy to get to know Isha through Mona's stories, and so powerful for us to hear about the difference, the way in which we approach our work makes in the lives of children and families. So it really drives home for me that our Our influence goes beyond our clinical influence, and we appreciate very much the opportunity to learn from Mona and other parent and family advisors who provide really inspiration for our work. I'm going to pass it now to Carmen Lazar, Practice Director for Provincial Occupational Therapy.
Thanks, Julie. Good afternoon, everyone. So we know that collaborative practice enables providers to deliver our services in a way that results in better patient outcomes. That's really why we want to enhance collaborative practice, is to improve outcomes. A child and family first approach, together with professional practice and action, support collaborative practice. So we have these key messages that I'm going to go into a little bit further around the child and family first approach, PPA, and collaborative practice. The child and family are at the center of what we do, and I love this photo in this slide. In fact, putting patients first is an AHS priority. Child and family first is an approach to care that focuses on the needs of the child and family, with healthcare providers working together to really wrap around the child and family based on what their needs are. Regardless of one's role on the team, we all have a role in supporting the child and family. The strengths and needs of the child and family are the foundation for how we then individualize our approach to service delivery. This client-centered approach requires that we ask the child and family to inform our practice. We ask them what matters. We will talk a little bit later in this presentation about collaborative goal setting. The client-stated goals are really what guides our intervention. Everything we do connects back to what the child and family need from us within an episode of care. That is what drives collaborative practice, what matters most to the child and family. Start with that. After all, they do come first.
It's Julie again, and I just want to say it's so great to see so many managers and practice leaders here showing your support for this work, really knowing that we provide excellent child and family-centered care through excellent professional practice. In this work, we really want to reinforce for providers that sometimes we think that our individual clinical competencies and skills provide the foundation for professional practice. And indeed, our individual competencies and skills are essential. However, the literature is clear, and our interviews with clinicians and leaders have reinforced that quality person-centered care depends on the support of a strong system, team competencies, and the individual clinician. Laura Lee Lingard's work demonstrates that team competence is more important to patient safety and healthcare than the competence of individuals. How our system enables clinicians and teams to work effectively is key to professional competence. How teams communicate and work together is crucial to safety and all aspects of quality. So we just heard about the difference communication and collaboration made in the life of Aisha and her family. Our individual competencies, including our collaborative competencies, are then integrated with team competency and system supports to put professional practice in action. In preparing the resources that you learned about today, clinicians work together to better understand the unique and overlapping contributions among team members and across disciplines. They were brave in challenging their own assumptions and those of one another. Regulatory colleges, AHS Interprofessional Regulatory Affairs, physicians, and multiple disciplines came together to create a robust set of tools that we believe will help you to put professional practice in action to address what matters to children and families.
Thanks so much, Julie and Carmen. We really appreciate your input and your partnership with us in this work. I'm going to speak a little bit to some of our collaborative practice toolkit that we've created as a working group. We were so fortunate to have been able to partner with COACT to harness the power of the work completed through this AHS initiative over the past few years. The COACT Collaborative Care Design provides a framework and approach to implementing and sustaining collaborative care across the care continuum. The guiding principles and pillars underpinning all COACT collaborative care elements include patients first, so patient and family-centered care, high-performing teams, enabling our teams for success, and quality culture, better value and better experience for our patients and families and our team members. Having the advantage of adopting and adapting COACT's carefully created materials has been a huge boon to the PEAS project and allows for continuity and consistency across care contexts and areas of practice. This graphic really illustrates the goals of the PEAS project with respect to building strong collaborative care teams and enhancing coordination of care and communication within the eating, feeding, and swallowing area of practice. The feedback from the PEAS World Cafes, as Vanessa shared earlier, indicated a disjointed or siloed current state, with teams separated by their discipline, their geographical area, or even the clinical program within the same site. Our goal is to provide teams with information and tools to help build care teams that are centered around the child and family and operating under a shared goal of best patient care with fluid communication between all members of the team, as you can see in the right-hand image. To promote interprofessional care, bring together the unique perspectives of varied disciplines, regardless of whether people work in co-located teams or are geographically spread out. As we mentioned, we had the benefit of working together with COACT to develop collaborative care elements specifically for PEAS, which have now become part of the PEAS Roles Handbook. The 4 resource bundles included in our handbook are listed on this slide and are designed to support the operationalization of the principles of collaborative care. They're interdependent and applicable across the care continuum. Now, instead of digging into each element individually during this presentation, I will show you where they are located on the PEAS website and encourage you to take the time to review each element yourselves. Now, on the website in the For Providers section, you'll see collaborative practice listed along the left-hand side in the list of contents. Simply click on collaborative practice and then read more under the collaborative care primers and resources section. The 4 elements of team charter, collaborative care team, assignment of care, and collaborative care leadership are accessible here as printable PDF documents. We'd like to share a bit more info about developing a team charter, as we've found this to be a very valuable and edifying process and kind of a foundational step for teams to undertake. Across Alberta Health Services, teams have found that developing a team charter facilitates ownership of collaborative working relationships in the care environment. It enables the team to function in an empowered manner and provides a link between the team's goals and AHS's overarching mission, vision, values, and goals. A team charter is a collaboratively developed description of the team members' responsibilities, accountabilities, and working relationships in the care environment. It defines the purpose of the team values, operating rules, and accountabilities. It provides the scope and approach to collaboration, outlines expectations, behaviors, and commitments. It also provides an agreed upon process to resolve interprofessional conflict. Creation of a team charter really needs to be initiated and driven by operational and practice leads. It's a living document that should be revisited on a regular basis and when new team members are orienting to the practice setting. And just a note to let you know that for teams who are going to be participating in our upcoming Innovation Learning Collaborative sessions, we will be facilitating a time for those teams to develop their very own team charter at our upcoming orientation session on November 25th. A little bit more information about team charters on the PEAS website. You can find access to a team charter primer or info sheet, a development guide, quite a robust development guide, templates and examples of charters developed by existing pediatric eating and swallowing teams, such as the one that you see here. This is an example of a charter developed by one of the eating, feeding, swallowing teams here at the Alberta Children's Hospital. Working through this process with a number of our teams has been really gratifying and productive. It's provided the opportunity for a shared reference point during role-related discussions amongst team members. On the website, additional collaborative practice primers and resources can be found just below the team charter and include collaborative care team, assignment of care, and collaborative care leadership elements. Each of these materials are brief, only 2 pages, and they include practical concepts, suggestions, and steps to implement and enhance collaborative practice. We would encourage you to review them with an eye to how these key principles of collaborative practice may be put in place in your context to support practice, process, and quality care. I'll just take a moment to highlight that, as you heard with respect to the team charter, it really is essential that operational and clinical leaders are involved in initiating and propelling the work around role clarity. I'd like to mention specifically that the elements of collaborative care leadership and assignment of care really need endorsement, structure, leadership from operational and clinical leads. Sorting out how a team can best work through the questions and the process of capitalizing on these evidence-informed elements of collaborative care, that'll be a unique process for each team. It really requires the participation of from all levels and all members of the team, including yourselves as leaders. We hope that your teams will take the opportunity to explore these collaborative care elements and that the process of working through them strengthens your collective interprofessional competence. And with that, I'm going to pass the mic over to Tricia.
Okay, thanks Melanie, and happy Allied Health Week, everyone. So going back to the original purpose of the Provincial project, lack of healthcare provider role clarity was one of the top concerns presented by families when attending the World Cafe meetings in fall of 2018. The CADIF evidence review in 2017 provides clear direction that a team approach is required to best support safe feeding and swallowing assessment, care coordination, and as dysphagia is considered a complex health issue. We will cover your role as operational PPL leads and in the use of the roles tools in this section of the presentation. The PEAS Roles and Implementation Working Group initially tackled review of the role resource supports for healthcare providers. Once the role resources were completed for healthcare providers, the resources were adapted for families to utilize in order to support the family's journey related to their child's eating, feeding, and swallowing care. So your department, unit, or eating, feeding, swallowing team, you as leads and managers can use these resources to have conversations with your teams about the services you provide to infants, children, and families. For healthcare providers, you'll find the AHS developed PEAS role descriptors and tasks within full scope is on the new website under the collaborative practice section. These tools are intended to be used together as a package where you'd find specifics related to role descriptors such as scope of disciplines and the overview of roles. In addition, the tasks for each discipline are a comprehensive list for an individual working at full scope of practice. And keep in mind that not every individual representing a particular discipline would be ready to work at full scope, but we wanted to make sure that each health discipline, college, or regulatory body confirmed each discipline's maximum scope. As PEAS is an advanced area of practice, we acknowledge that individual healthcare providers may seek additional training and mentoring in order to work at full scope of practice. These tools are used by practice leads or operational leads, and the task chart can be adapted for your specific team. Together with families, clinicians, AHS health professions, strategy and practice, AHS COACT, the professional colleges, the PEAS project has developed PEAS roles, descriptors, and tasks within full scope for healthcare providers. And those things are, as you see on the slide here, a few areas such as providing clinicians with an adaptable tool for highlighting, communicating, and clarifying overlaps and gaps, within the team, also promoting interprofessional care, focusing the care team members on their collaborative team competence to address the child's family-centered goals, and finally, provide a tool to identify and cover gaps in services. As part of the roles, descriptors, and tasks within full scope tools, we've developed a diagram that addresses roles such as the one on the left, outlining the multiple and different care providers, some of those including the dietitian, OT, SLP, psych, physician, nurse practitioner, nurses, lactation, and other areas, their different training and skills, and of course that absolutely central role of the family in interdisciplinary care. And you'll notice that Vanessa worked with a group for the visual aspect, ensuring that you can see how things are overlapping because the color and lines are all intermingling. When we look at the triangle displayed, we have clarified that individual scope of practice is determined by ministerial regulations, professional regulations, employer policies, and the individual competence. These tools can be used by practice leads or you as operational leads on the line in your team meetings to support understanding of the importance of interprofessional collaborative care and to have meaningful conversations about the care we provide to babies, children, and families as an eating, feeding, swallowing team. So just want to share kind of a local story. At Medicine Hat Regional Hospital, our team thought it was important that staff and managers, we had better clarity on roles based on past confusion. So we looked at the sustainability of this service when providers moved around from unit to unit or were taking on different positions. And every time we review a team's functioning on various units or sites, we would want to look at the roles first. This allows for respect of the various roles on the team. And the work can be complicated and touchy, but it depends on each team's composition. So we needed to review our scope of practice and then look at overlaps to determine what we were comfortable doing as a team. And we learned a lot together. There were aspects of service we discovered to better serve the family, such as using the hospital education team. Wayfinding was improved because we had a better understanding of where to transition a child and family in the community. So whether, they're transitioning from acute to community, outpatient, public health, allied health. And we wanted to discover who was the most appropriate person to do the task on our team for the safety of the baby or child. Each team documented their decisions on the chart for transparency and clarity, and it built our understanding of when to involve another discipline, pending the roles decision we made as a local team. And after reaching that consensus on discipline functions at our hospital, team members and managers expressed greater satisfaction with how we deliver services to babies, children, and families. And we also have Melanie with an example.
Yeah, thanks, Tricia. Here at Alberta Children's Hospital, an opportunity was identified to ensure that a full interdisciplinary feeding team is consistently available to infants and families in the neonatal intensive care unit, and to enhance coordination of care around eating, feeding, and swallowing in that area. We worked to ensure that there was FTE available from each of the disciplines identified as key players in feeding, including nursing, neonatology, dietetics, lactation consultancy, occupational therapy, speech-language pathology, and social work, not to mention a focus on highlighting the parents as expert team members. Weekly feeding rounds were initiated, which has allowed real-life experience to guide role clarity and collaboration between team members. Feeding plans are being made and are agreed upon by the family and interdisciplinary team after discussion, collaborative discussion, and input. So far, feedback from the team is that the service has become much better coordinated, care is shared and more efficient, the level of service availability has improved significantly, and in some cases, the length of stay is even shorter, which is fabulous. From the nurse practitioner who spearheaded this work and continues to provide leadership to this team, she shared this quote with us. She said, "This work has brought the team to a point where we are cohesive. It's amazing and so important for our babes and families. Thanks.
Okay, thank you. So in addition to the roles, descriptors, and tasks within full scope, we worked with the AHS Interprofessional Regulatory Affairs to create a frequently asked questions document that can be found in the additional resources section of the PEAS website under collaborative practice section, as you can see on the screen. In Alberta, all healthcare professionals are required to follow provincial healthcare laws and professional college standards, employer governance, and self-regulation when they provide healthcare services to patients and clients. These requirements are primarily in place to ensure Albertans receive the quality, safe healthcare service. Healthcare professionals from different disciplines may have similarities in their education and training, but despite these parallels, the role of each profession remains distinct and defined by professional practice statements, regulatory college standards of practice, and competencies in Alberta. So with the restricted activities, the Government Organizational Act, Schedule 7.1, contains a master list of healthcare activities that are restricted. These activities are restricted because they're considered to be risky and require specific education, training, and competence. Secondly, the term diagnose is not a restricted activity. Some professions have it within their scope of practice, such as practice statements, college standards, competency profiles to diagnose, and others do not. The dictionary defines diagnosis as recognizing and naming the exact character of a disease or problem by examining it. Third, the Health Professions Act is a framework document that provides common provisions that apply to all regulatory colleges and schedules that apply to specific professional colleges. All regulated healthcare professionals have profession-specific regulations that provide governance for the profession. These regulations provide direction for what restricted activities the profession is authorized to perform and under which circumstances they can be performed. Fourth, in terms of collaborative practice, when working in an interprofessional collaborative team, when working in an environment where different regulated professions care for the same patient in an environment, each regulated member works under their own legislative, regulatory, and college standards, and remains individually accountable for the care. And lastly, the role of AHS in directing how professions practice. AHS is accountable to uphold Canadian and provincial legislation, regulation, and accreditation standards. AHS develops processes, resources, and tools that support regulated professionals to practice safely and provide quality care. Those AHS strategies, values, and competency statements help to describe expectations for staff working at AHS. And AHS, of course, has the authority to decide on the role of a profession in their specific position, but AHS may not insist that a profession perform authorized restricted activities that are outside of professional scope. And that, again, is under the Government Organizational Act. So just moving on to the displayed screen, we're just going to look, you'll see additional resources page. And under there, I'm just going to flip my screen here so I can take a look at what's on there. You'll see various sections, and I actually probably need your help, Vanessa, because I don't have the right glasses on. But you'll see videos, great resources that we determined as a team or as a working group that would be helpful to you as professional practice leaders, managers, and as your team as well, or for your team as well. And then moving on, we have resources for family members who are an important and that imperative member of the care team. They have an integral role as indicated in the literature, in COAC principles, and in health change methodology, all endorsed by AHS. There's also information about self-care and involving people in their community, like people from the school, friends, other family members, siblings, as well as information about finding a support network, including links to peer support networks for families who have children with an EFS disorder. And this was highlighted by Mona in her presentation as well. Under the family section, we also have information for families about their care team and various roles that each provider may have. Mona highlighted this in her presentation. This circle diagram is similar to the one for healthcare providers, but we ensured that is written for families. And finally, in the care coordination section, there's also expandable questions for each family to explore. And I'm just going to click on it here so I can see it a little bit better. So just for example, what is my role as a parent? Who do I talk to about food preferences, emergency health planning, etc.? So that's the introduction to that section. And I'll pass it on to Carmen.
Great, thank you, Tricia. Okay. So there's been much provincial work over the last couple of years, or few years really, related to collaborative goal setting. These successes are because of your work locally and within your zones and as participants in provincial work such as the PEAS project. So we're going to talk a little bit for a moment about what is collaborative goal setting, and I'm looking at the attendee list and thinking, wow, there's a lot of great clinicians on the line that would be able to jump in and really talk about this as well. So I'm here to give a bit of an overview for sure and contextualize this for the conversation today. Clinicians and teams intentionally engage clients and families in a shared decision-making process, resulting in functional client-centered goals. The client is the expert on their values, their preferences, their motivations, whereas the provider is the expert on the condition and the rehabilitation process. So this is really a two-way relationship where we are seeking to understand from the client and family, from the child and family, seeking to understand what their needs are, what their motivations are, what they desire, and to build a shared understanding of the goals for treatment. Collaborative goal setting improves client outcomes. When clients and families are actively involved in making decisions about their goals, their engagement, their satisfaction, and their motivation improves. In practice, this translates to improved clinical outcomes, greater client commitment to the rehabilitation process, and improved self-management, with fewer no-shows, fewer cancellations, fewer readmissions, and really supporting discharge. And, as if that's not enough, it has been and still is an organizational priority. The patient-first strategy and patient-centered care are expectations of practice within AHS. Collaborative goal setting is an explicit way to ensure that we are asking children and families what matters to you and collaborating with the team in order to deliver our services. So this is reasonable and it's definitely evidence-based. But how do we actually do this? What tools do we need to do this as teams? And what teams already apply collaborative goal setting in their practice, and how can we leverage that? For some, it might be more a new skill set, and for others, it's something we do already, but maybe we just need to standardize it further or improve continual improvement for the process that we use. So applying collaborative goal setting in practice is something that we have not necessarily achieved consistency across AHS. So we want to spend some time and, Connect Care is a great opportunity, for example, to think about how do we improve consistency and what can we start to apply in our practice today. Goals should be recognizable to the child and family. They should be able to say, yes, that's what's important to me right now. They should feel some ownership that they own those goals and that they know what they mean and where they're headed. So it's not my goals as an occupational therapist that the child will be able to maintain trunk control, for example, or be able to use a spoon for eating yogurt, but instead it might be that the child and family goal is to eat breakfast together as a family, and we are then taking actions towards that functional goal. Goals are also not pre-configured. We don't know what the child's goals are based on the health condition that they come to us with or, the reason for referral. even their presenting symptoms and functional issues don't really tell us what the goals are. So they're really not pre-configured. They're not from a drop-down list that we've created based on the diagnosis, for example. They're really, we don't know what they are until we have that conversation and engage in a shared decision-making process to establish what matters most to the child and family and what matters most right now in the context of where they're at right now in their life and in their journey. So we've covered the why behind collaborative goal setting, and now let's focus a little more on the how it is done. And how do we know if we're applying an evidence-based approach to goal setting? There are 4 principles to keep in mind. Collaborative goal setting involves shared decision-making, that the goals are client-centered and client-stated. The goals are what drives intervention, and the goals are documented. It is through a shared decision-making process that we engage the child and family in establishing their goals, and that the goals we land on are indeed client-centered, can drive intervention, and can be clearly documented. And so my final couple slides are going to really just go into a bit more detail around clinical documentation of goals. While Connect Care is not the focus of today's presentation, it's important that we, to really just know for future reference, that we've built multidisciplinary tools in Connect Care that support collaborative goal setting in practice and allow for documentation of goals and treatment plans by the team. Currently in Connect Care, providers have access to an inpatient collaborative goals and treatment plan flow sheet where they can document client-stated goals and the tasks associated with working towards each of those goals. And in the ambulatory platform or environment, providers can use what's called the treatment planning activity, which is a nicely packaged piece of software for easy documentation of goals and tasks. In both cases, there is the ability to document on progression of tasks as well. Until all programs and services have transitioned to Connect Care, there are other tools to support practice in current documentation systems. And a great example of this that has been adapted for use across Ps is the goal wheel. The center of the goal wheel is the client-centered goal statement, and the shared decision-making process is used to identify the actions or tasks that will enable progress towards that goal. So providers may find it helpful to review an example of a completed goal wheel, especially if it's newer to their practice or they just haven't used this particular form before. So we have worked provincially to develop some examples, and one that we'll share today is Mona's example. So Mona collaborated with an occupational therapist to complete a goal wheel form that we're seeing here, with a focus on the overarching goal related to meal times. And Mona's not with us today for this presentation, otherwise I would get her to speak to this, but I'll do my best. So Mona stated that she wanted the confidence to be able to include her daughter in meal gatherings with family and friends. So you see that this is written pretty much, you could put quotes around this. It's written as the client stated goal at the center of the goal wheel. And then around the boxes around that goal are the actions or tasks that support progress toward the goal and include sort of identifying things like, okay, we need to seek out, identify an appropriate chair, positioning techniques, what kind of practice will happen at home before going out into public, for example, practicing eating similar foods to what will be offered at that intended family gathering, for example, providing education and resources that will support the child and family through self-management, and exploring things like psychological services to support the family. And the bottom right box includes that sort of graded, very OT approach, graded introduction of activities that will offer opportunities for success as the family moves toward that overall goal. The client and healthcare provider agree on and have a shared understanding of what these actions are, what the tasks are, and agree on what the next step is to take. The goal wheel is a coordinated group effort approach to care. So while this one was filled out through an occupational therapist working and talking to Mona, absolutely it could be added to and would represent other disciplines on the team as well, so that everyone knows what the goals are and how we're all working together towards those same things.
Okay, great.
So you can contact us by email, as you see on the screen, or we'll show you the PEAS contact form on the next slide. You could feel free to suggest any additional tools or handouts that you would like to be reviewed by the PEAS leadership working groups. Tools that are approved would be posted on the PEAS website. Here's a form that was just mentioned, another mechanism for you to contact the PEAS project. Please also consider subscribing to upcoming news and events through the PEAS website. And you could subscribe to the PEAS community of practice. So just wrapping up, this brings us to the close of the presentation, and again, really value the participation of the PPLs and managers, the leaders in Alberta related to pediatric eating and swallowing. We just welcome your comments or questions. And I think we'll just, before we do that, I also wanted to make sure to, as chairs of the PEAS Collaborative Practice and Roles Working Group, Melanie, Vanessa, and I would like to reiterate our gratitude to the working group members that we highlighted earlier, and the PEAS Steering Committee has provided us with great leadership and guidance in the journey. We're thankful for their steadfast clarity whenever we've had questions with the work. Thank you also to PEAS leadership team, and of course the family advisors and family members who have supported the purpose and vision of this work being like our North Star. So if you could consider completing the 5-minute survey regarding your feedback on this virtual training session, that would be very helpful. Thank you so much.
Thanks, Tricia. If I could just ask you guys to hang on for a couple more minutes. This is Julie again. Yeah, I just want to really reiterate a huge thank you to all our working group members and to those of you on the line who have supported their participation. I know it takes a lot of juggling to make this happen, so thank you. The quality and depth of the resources that these groups have created for us is astounding, and to Mona, where she here, the website is fabulous. Before we close today, we would just like to take a moment to remember Wendy Johansson, who was part of the Roles and Implementation Working Group. Wendy was a highly skilled and compassionate clinician who made a real difference in the lives of so many infants, children, and families. Across the healthcare system, we relied on her, and in fact, I relied on her for clinical expertise and passionate leadership in the area of pediatric eating and swallowing. Wendy was truly a force within PEAS, within the PEAS project, touching on all aspects of service improvement. She had such a clear vision of our ability to create coordinated and truly excellent services for infants, children, and their families. Wendy Johansson passed away on July 21st, 2020. Her legacy really lives on through our work to improve services for children and families. We will continue to honor her. So let's take just a moment right now to remember Wendy. On behalf of the PEAS leadership, I would like to express our condolences to all of Wendy's colleagues, friends, and loved ones. Thank you, Wendy. And thank you, everyone, for joining us today. Please follow up if you have any additional questions or comments.